Good afternoon, everyone. So, thank you, GlobalMeetx, for giving me this opportunity for sharing a small bit of knowledge on ulcers of oral cavity. Myself, Dr. Abhishek. I'm basically from West Bengal, but I'm associated in academics at Awadh Dental College Hospital, Jamshedpur. And this ulcers of oral cavity is always a cause of distress to the
هاي
patient.
مؤتمر خليني أفتح هاي توني جاية من عند
So going on with the first case presentation, that is this is a very small ulcer which we can see generally in the
For consult, preferred by OMFS or treatment planning with missing.
I request the background sound to be stopped. Yeah, so this is like the aphthous ulcers, which may have many factors like stress, immunological problems, and lot of things. But gradually, it just needs the patient's consideration. Like it's okay that you will get it healed within some days, and it do not require much of medicine or much of a fear, much for biopsy or anything like that. But yes, if it is persistent for a longer time, then we need to evaluate like that. This is a particular case which we usually see in the lateral border of the tongue. And what we can see exactly is a central erythematous halo followed by a whitish surrounding. And this we have to generally go back and we have to actually look into the habit history. Also, we have to look into any sharp teeth is there. So generally, this small pinpoint ulcers in a very clear, good, fair oral cavity, these are generally a traumatic origin. Exactly need much of a concern for that, but we need to remove this particular problem. So we have to go for a selective colonoscopy of the tooth, offending tooth, and we have to keep the patient in follow-up. But sometimes what do happen, this is the case where the tooth is so we can see almost we can see a decayed tooth over here and a particular cusp is totally impinging. And this has become such a chronic issue that the patient is really worrying about like why it is not healing. So there is a induration as per the reactions, as per the tissue reaction and everything that is on the lateral border of the tongue. But this is such a very big lesion that cannot go just by itself. So first we have to go with the incisional biopsy. So whether it has gone for any malignant or any malignant changes or not. So what we found is like a lot of inflammatory cells into the deeper connective tissue and also a macrophages and blooding vascular channel. So this is traumatic ulcerative granulomatous stromal eosinophilic ulcer. So this is absolutely benign. So then we have decided for a major excision of that particular lesion and we have asked the patient to keep in follow-up and the patient was absolutely okay. So this is one benign thing that also do happens with the lateral border of the tongue. Now what we can see over here that this is a ulcer, this is happening for more than some 3 to 4 weeks and what we can see is like the 6 is there which having a porcelain crown and behind that there is no tooth. So there is a very severe bite that the patient has undergone while eating food because there's a big buccal pad of fat which has come in between the occlusion because there is nothing to support at the 7 healthy and have the cheek. So this ulcer is not healing. The patient is again patient has been again referred to me in relation to this to take a biopsy for that. But when the patient gives me a history that this was not behind and patient is not having any patient is not having any habit history or something, we reassured the patient and we told that let us do a follow up and we have done a fine shaping for that crown so that it does not and we have removed the sharp cusp of the upper so that at least we can give a supportive measure for this particular. So this was again a traumatic ulcer. We do not require a biopsy for this until and unless it is very much required. Now this is one more case that is known as it generally occurs in the posterior lateral surface of the tongue and exactly in the posterior most surface of the tongue. And what exactly do happens, like there are few areas which are inaccessible for maintaining the proper oral hygiene. So generally what we can see is a fungal commensal over here, and this is the fungal infection which also predisposes to give a hypertrophic papillitis. So this is a second case of again a foliate papillitis. So again, it do not requires a biopsy for that. We have already published these cases because it's a major cause of cancerophobia amongst the patient, and they usually tell that I'm having pain in the posterior aspect of the tongue. And we do not require biopsy for this, but we can definitely subject the patient to some antifungal drugs, topical, and some NSAID gels, which can give a symptomatic relief, and it will heal off by itself. And special mention for maintaining the oral hygiene. This is one more case of same traumatic lesions, which presented as an ulcer, but it is exophytic. And this is like a herniation of the tongue fat, which has come to the level surface up. And it gives a very fiery look, but it is absolutely benign and turned out to be a fibrolipoma. But yes, for this type of particular case, we can see the patient is a male and has no habit. But this is due to the trauma. So we have excised of the entire lesion and turned out to be a fibrolipoma of the tongue. This is one more example of a traumatic lesion which looks like that. There is no induration at the periphery of the lesion, and there is no peripheral induration at the periphery of the lesion, and it is absolutely fine. And so we have to just do a selective coronoplasty, and we have to look. So what is my major concern is, like, we have to know that whether we have to go for any investigation or whether we have to go for a reassurance of the patient's education is very important, and before that the
Excuse me,
clinician
doc.
himself or herself need to be more
Can you,
educated
excuse me,
related to the
doctor?
lesion.
Can you please move up your slides? We are seeing only first slide.
uh, is there any problem with this?
We are only able to see first slide.
That is what I am asking, whether it is coming or not.
Now okay, doctor.
So this is a particular case of the lateral border of the tongue. This is the ulcer which is seen in the lateral border of the tongue. And what we can see is a very faint lesion which is there. The patient is a chronic user of gutka and other tobacco agents. When we took the biopsy of this particular case, it turned out to be a malignant form of ulcer. And this is like an initial form of malignancy. So when we actually go with this type of lesion where we see a pre-leukoplakic area, we see a very pre-leukoplakic area, and so we see a one ulcerative area and a one pre-leukoplakic area. We need to take the biopsy from both the sides, and we should rule out what kind of ulcer it is. Here, what we can see is a very angry lesion over here, but what clinically there is a root stump. Patient is having no habits, but the chronic irritation to this had led to the early stage of malignancy. When there is some hidden lesion exactly in the OSMF type of cases, patient, it's very difficult to retract the buccal mucosa. We have also seen a supra-eruption of a particular teeth and a ulcer which is well pressed with the teeth. On OPG, what we can see is a bone invasion. So definitely this is something which is very aggressive, and it turned out to be a malignancy on biopsy. So this type of case where you see a lot of destruction which can be anticipated as a malignancy, we need to go for a incisional biopsy. This is one more case. I do not have the clinical photograph of this case, but it looks like a non-healing ulcer over the ridge, and we can see a lot of mottling over here, a lot of destruction over here. When we went to the ask about the history, the patient is already suffering from some kind of a bone disorder, and which is affecting the other parts. So there are many punched out lesions in the other parts of the body also. So this was very consistent with the finding of multiple myeloma. And then we found out the previous reports also suggestive of similar thing, where we see a lot of plasma cell proliferation, bony destruction, and so this need to be carefully evaluated. What kind of ulcer? Is there any implication? Is there any effect on the bone, underlying bone? So these all things need to be carefully seen. This is one more case, similar case, but on the other side, the same ulcer which is not healing after the tooth extraction. And we got a very small amount of curettage tissues which we got, and it turned out actinomycotic osteomyelitis, and we can see a lot of sun ray type of appearance over here, the bacterial colonies. And this is one more case which has multiple lesions across the mouth, and what we can see is again osteomyelitis. Unfortunately, we lost the follow-up for the patient. Patient was from a very uneducated background and a low socio-economic status. So patient didn't turn up again. This is again from the same alveolar ridge, a non-healing, but there is an ulceroproliferative. We cannot see exactly the borders. It is all smudged up. So generally, when we see this type of ulcers, we usually we need to go for a biopsy. This patient comes up 12 hours after access opening, and there was a unilateral lesion. There was also ulcers, and the patient was very much hesitant to continue with the RCT. It was done somewhere else, and he wished that he just when actually there's a case of herpes zoster infection. That is there was a lot of hematology spikes of IgG and IgM. So this is very common type of viral affliction, but we need to diagnose it very carefully. So what we have given oral dose of acyclovir 400 BD for almost like 7 days, and it subsequently healed a lot in the follow-up of the 10th day. So this one more, this is a very peculiar lesion. What we got kind of a mirror image in the right and the left. And there are very few literatures based on that which suggest it is a herpengia kind of lesion, that is again the viral. But we could not correlate much to any viral, but it's still in the question mark. But this is a very peculiar, and patient also had fever, fever for 2 to 3 days, and usually occurs in the children, but it was found in the adults. So I just thought of just sharing this image with you. Generally, old ladies and people who do not maintain a good oral hygiene has a very deep ulcers on the tongue. It is usually a fungal affliction, and we need to keep in the fungal regime. Do not need to take any biopsies initially until and unless it shows no improvement at all. It takes a good amount of time because you need to because these people are generally immunocompromised, and because of this they usually get this all deep fungal infections, and so we need to keep them under itraconazole or fluconazole 150 BT like that, and we have to subsequently do a good follow-up. But yes, for this type of cases, initial biopsy is not much required. We have to look into the systemic medical conditions of the patient also, because patients who are having this all take this rotahelor and all this inhalation corticosteroid, they usually get this when they don't clean their mouth properly. This is a patient, male of middle aged, who had very severe ulcers, very difficult to take even water. So we did a very superficial biopsy, and what we found, it is a epithelial blister, that is the pemphigus. So we have referred that patient to the dermatologist after a initial corticosteroid treatment. This is a very similar case, drug eruption, drug-induced pemphigus. On a change of a antihypertensive, we could see such big ulcers immediately from the very next day. It has even seen in the nasal cavity also. The young patient whose parent tells us that every year there's an outbreak. And the only treatment we gave is antiviral, that is acyclovir, followed by a prednisolone to just reduce the inflammation. But yes, for this type of cases, again, biopsy is not much required. We have done a HSV HPV profiling, and we found that again for the HSV there's a IgG IgM spike is there. This patient complains that some secretions comes out from the alveolar ridge, and when we actually palpated that region, we found it a very keratinaceous material. So we thought of doing a biopsy from very deep inside, and what we found is a squamous cell carcinoma. So this is a very rare variant, like de novo, like suddenly it is a primary intraosseous squamous cell carcinoma which has no mucosal this thing. So generally, this is what the different cases are, like a plethora from the traumatic lesions to the aphthous to the autoimmune to the microbiological. So we need to keep our eyes very much open, and we should look what investigation actually suits well. So thank you very much for giving me this opportunity. There was some technical glitch. I could not do a full screen for this, but anyways, I have conveyed the few cases. I'm readily available at my mail. Also, my phone number is there with the coordinators. Thank you so much.